So it's my great honor to introduce Steve Nissen, who's the Chief Academic Officer for the Heart, Vascular, Thoracic Institute at the Cleveland Clinic, the Lewis and Patricia Dickey Chair in Cardiovascular Medicine, and Professor of Medicine at the Cleveland Clinic, Lerner College of Medicine. He's also the Chair of the Department of Cardiovascular Medicine at the Cleveland Clinic. And in 2006, 2007, he was the president of the American College of Cardiology. He's authored more than 600 journal articles and 60 chapters. He was named by Thomson Reuters as one of the world's most highly cited physician scientists. And it's my great honor to introduce my friend, Steve Nissen, who's going to talk to us tonight about issues with statins and bempedoic acid and really how we move forward in this area. So without further ado, Dr. Nissen.
Thank you, Guy. And I'm going to just get right into it so we have some time for questions. And what I wanted to do is kind of talk about statin intolerance first, and then share with you the results from the CLEAR outcome trial that we recently reported at the ACC meeting and published in the New England Journal of Medicine on the use of bempedoic acid in these patients. I think many of you, because this is what you do for a living, know that this is one of the most vexing and elusive clinical problems that all of us face. This is also my disclosure slide, but please understand that I do not accept any reimbursement from industry for any reason. So the question is, how common is statin intolerance? We really don't have as good a data as we would like. I think this PRIMO study probably is one of the better ones. It was almost 8,000 patients. And overall, about 10 or 11% of patients in this trial, or in this study rather, not a trial, in this study, had statin intolerance, but it varied by drug. And I think most of you know that with regard to particularly myalgias, simvastatin is the worst. Some people think pravastatin has less. I don't actually agree with that. And fluvastatin has the least, but of course it's the least effective at lowering LDL cholesterol. Typically, and this is, I think, one important contribution from the PRIMO study, people are going to develop symptoms within a month or two. Somebody comes back and says, oh, I've been taking statins for 2 years and now I have terrible myalgias. Something's wrong. Something has changed, and maybe they've developed another condition that's caused them to have statin intolerance. But typically, you're going to see it in the first 1 to 3 months of treatment. Median time to symptoms was 1 month. Kaiser has a real-world database. They reported at this pretty good-sized study 5 to 10% statin-associated myalgia. Many of them have myalgia alone, but not uncommonly myositis with CK elevations. And then the more severe forms of severe CK elevation or rhabdomyolysis clearly are very uncommon. What are the symptoms that favor statin myopathy? Well, proximal pain or weakness in large symmetrical proximal muscle groups, worse with exercise, typically resolves within 2 weeks of statin discontinuation. Statins return within 2 weeks of rechallenge. Sometimes mild hyporeflexia, but normal pain, vibration, and position stents. And normal CK, normal TSH, normal ESR, normal CRP, and normal levels of vitamin D. Risk factors have been pretty well identified. Older age, women, as you're going to see in a minute when I show you CLEAR outcomes, more common. There clearly is a genetic component, to some of which has been elucidated. Pharmacodynamics for sure, drug-drug interactions, for example. Definitely dose-related, higher doses, higher incidence. Multi-system disease. Patients that are transplant patients have a higher incidence. Perioperative period, obstructive liver disease, hypothyroidism is a big one. I've had many patients where you correct their hypothyroidism and their statin intolerance goes away, renal failure, and then the extreme athletes are really problematic because they are the ones that are going to complain the first because they're performing at the highest level. Now, we did a study. I'm going to summarize. It's a complicated study we published in JAMA, but I want to just mention what we did because I think it's informative here. It's called Gauss-3, and we enrolled about 500 patients at 50 centers, and they either got atorvastatin or placebo, blinded for 10 weeks. Then they crossed over, and the placebo patients received atorvastatin, and the atorvastatin patients received placebo, also blinded. And we then were able to find out whether patients had symptoms on placebo alone, on atorvastatin alone, on both, or on neither. And here's what we found. 42% of these patients, 43%, had symptoms on atorvastatin, but not on placebo. 26% had symptoms on placebo, but not on atorvastatin. 10% on both drugs, 17% on neither drug. And so what you see here is there's clearly an excess of symptoms in these patients on atorvastatin compared with placebo in this crossover study, which I think is about as informative as we could possibly be about whether this is a real phenomenon or not. As you know, there's been a lot of pushback from the Oxford group that says that they say that this is not a real phenomenon, but I think Gauss-3 shows that it is. So with that background, let me talk about CLEAR. We started this study quite a long time ago with bempedoic acid, and I want to walk you through what we did and why we did it. This was the team. I chaired the study, but Mike Linkoff and Steve Nichols were my co-principal investigators, and we had a good team of people. Many of these names you'll recognize as very thoughtful lipid experts, and other people like Paul Thompson, who's an expert in statin intolerance. So these are the slides I showed at the meeting, and I pointed out how vexing this problem is because it prevents patients from achieving LDL levels associated with cardiovascular benefits. We know that statin intolerance is a malignant disorder because it leads to a high level of cardiovascular events, well documented. Bempedoic acid, for those of you that are not familiar, is an ATP citrate lyase inhibitor. It inhibits cholesterol synthesis upstream of HMG-CoA reductase, which of course is the target for statins. But it's a prodrug. It's activated in the liver, but not in peripheral tissues. That results, at least theoretically, in a low incidence of muscle-related adverse effects. Although it was approved in 2020 for LDL lowering, the effects on cardiovascular outcomes have not been previously assessed, and the drug is not as widely used as a lot of people were predicted because there were no outcome data. So here are the pathways. And you can see that, you can see the HMG-CoA reductase step where statins are inhibitory, and you just go upstream and you can see ATP citrate lyase, which is where bempedoic acid is acting. On the right, you see not the hepatocyte, but the skeletal muscle cell. And in the skeletal muscle cell, bempedoic acid is inactive. It can only be activated once it gets into the hepatocyte and gets converted to bempedoyl-CoA, which is the active form where it can do its work. So very cleverly designed so that it works in the hepatocyte, but not in skeletal muscle. This study was difficult to do. Obviously, we had to do some very careful enrollment criteria in order to make sure we got the right patients. So these people had to have an adverse effect that started or increased during statin therapy and resolved or improved after the therapy was discontinued. They had to fail 2 or more statins or one statin if unwilling to attempt a second statin or advised by a physician not to attempt a second statin. They could take very low dose statin therapy, such as, rosuvastatin 2 days a week, something below the lowest approved dose. I would add that about 80% of these people had failed at least 2 statins, and some had failed 4, 5, or 6 statins. They had to be primary or secondary prevention patients. Important that we had both groups in here, and they had to have an LDL of greater than 100. They were randomized 1-to-1 to 180 milligrams a day of bempedoic acid or a matching placebo. And like all contemporary outcome trials, it was event-driven until we had 1,620 primary 4-component MACE events, 810 key secondary, that's 3-component MACE, and 24 months of follow-up was the minimum follow-up to avoid the kind of problems that occurred with studies like Fourier, where they had an inadequate follow-up to see adequate separation of the Kaplan-Meier curves. Now, for this trial to be ethical, we required patients to sign the following statement. I can't tolerate these medications called statins, even though I know they would reduce my risk of a heart attack or stroke or death. And the provider had to sign a statement that said, in my opinion, this patient is unable to tolerate statin therapy, except possibly very low average doses below the lowest approved dose. This was required in writing for every patient. Now, we had a hierarchical testing procedure that's important here statistically. First, we tested for the 4-component endpoint: non-fatal MI, non-fatal stroke, coronary revascularization, or cardiovascular death. If we were successful in achieving statistical significance, we could then move through a hierarchy of key secondary endpoints. First, 3-component MACE, MI, stroke, or death, or CV death. If successful, we could then move to fatal and non-fatal MI. If successful, we could then move to coronary revascularization, and so on through this 6-component hierarchy. As long as statistical significance was achieved, we could move to the next step. But as soon as we failed on any of these measures, we had to stop computing p-values. Let me show you how far we got. Okay, study milestones. We actually enrolled a little more than 14,000 patients, but we had to remove about 45 of them that were deemed fraudulent patients at a site that obviously was run by criminals, and at 1,250 sites in 32 countries. Big global trial, lots of sites. Patients were enrolled between December 2016 and August 2019, with a median duration of follow-up of 40.6 months. Adequate exposure time. We ran this trial right through the pandemic, and despite the pandemic, I'm very proud that our team was able to get complete assessment of the primary endpoint in 95.3% of patients and vital status in 99.4% of the patients. We had great investigators, we had great leadership from both the company and for our coordinating center, and we got the job done. We got 4-component MACE in 1,746 patients and 3-component MACE in 1,238, both of which well exceeded our targets. Who were these people? Their mean age was 65 years. When I presented this to the ACC meeting and I mentioned that we had 48% women, only happened to me once before at a late-breaking trial, the audience broke out into a spontaneous applause. They understood the importance of having more women in clinical trials. Their LDLs, as you might guess, were high, 139 on average. They were 30% high-risk primary prevention and 70% secondary prevention. And because diabetes was an enrollment criteria for high-risk primary prevention, we had a lot of diabetics, almost half, 45% or so. And a smattering of patients were on these low doses of statins. Here's what happened. At 6 months, which is where we pre-specified we would look, we had a 21.7% reduction in LDL with bempedoic acid. Somewhat more than ezetimibe, but still not what we would see with a statin. Those differences converged over time as there was additional drop-in, that is, additional lipid-lowering therapies were added in the placebo arm. You would expect that, even though the sites and the patients were blinded, we saw much more drop-in in the placebo arm. We also had a very robust anti-inflammatory effect, a 22.2% reduction in C-reactive protein that persisted through the course of the trial. And I think this may have actually had a fairly substantial impact on the results. So here's the primary and first key secondary endpoint. 4-component MACE hazard ratio 0.87, a 13% reduction, a 1.6% absolute risk reduction, number needed to treat 63, which is considered favorable, and a p-value that was quite strong at 0.004. 3-component MACE, the more rigorous endpoint, actually had even a better hazard ratio, 0.85. The p-value was 0.006, quite a good result for both 4 and 3-component MACE. Where things got even more interesting was with fatal and non-fatal MI. Very big reduction in myocardial infarction, hazard ratio of 0.77, a 23% reduction with a p-value of 0.002. And you can see that after about 6 months, the Kaplan-Meier curves separate, and they continue to separate progressively through the course of the trial. We also saw a big reduction in coronary revascularization, a hazard ratio of 0.81, a 19% reduction. The p-value was 0.001. Again, benefits occurring certainly within the first 12 months and progressively increasing over time. So we've now gone through the first 4 endpoints, and we're still significant, so we get to move to the next step in the hierarchy. And the next step was fatal and non-fatal stroke. And you'll notice that while the hazard ratio is 0.85, the upper confidence interval is 1.06, which means it wasn't statistically significant, and so there's no p-value reported. Next in the hierarchy was hospitalization for unstable angina, and we actually had a hazard ratio there of 0.66, but no p-value was reported because we had failed on stroke, and therefore we were not able to test for unstable angina. What about cardiovascular death? Like every contemporary trial of LDL-lowering therapies, including the PCSK9 inhibitors, including ezetimibe, completely neutral effect on mortality endpoints. We have gotten very good, thank goodness, at preventing death from myocardial infarction. People with coronary disease are living a lot longer. Mortality is a much later outcome. I have no doubt that in a long enough study, we would see mortality benefits. This looks virtually identical to what was seen for the PCSK9 inhibitors. No effect on either CV death or all-cause mortality. Now, everybody wants to know, how did this line up with the cholesterol treatment trialist collaborative meta-analysis? And what you see here is that for the same endpoint as CTTC, our hazard ratio was 0.85. If you make the calculations, our LS mean difference in LDL cholesterol was 0.67 millimoles per liter. That calculates out to a hazard ratio of 0.846. Doesn't get any closer than that. So this falls along the CTTC meta-analysis regression line. What was unfortunate here was that there was more cross-ins. You can see that more statins, more ezetimibe, everything was more commonly given to the placebo patients, even though the investigators and patients were supposed to be blinded. That caused us to have a little bit less, actually quite a bit less LDL reduction than we had expected, but we still got where we needed to go. We would have probably seen even more favorable hazard ratios had we been able to prevent these cross-ins. And this just shows you the time to cross in. Clearly, within the first 12 months, there's separation, and it gets worse and worse as time goes on. So more patients than placebo got additional lipid modifying therapies. What about adverse events? Well, the key was, did we see muscle disorders? And we didn't. And I could have put in here myalgias. Every measure of muscle disorder shows no excess in the bempedoic acid group. There was no excess of adverse events leading to drug discontinuation or other serious events. What is really interesting here is there's no increase in diabetes. Every measure of blood sugar shows that bempedoic acid is neutral or a little bit better than neutral. So unlike statins, it is not increasing the diagnosis of diabetes. We did see, like all lipid-lowering therapies, active therapies, some hepatic enzyme elevations in excess of placebo. We saw a 1% increase in gout and a 1% absolute increase in cholelithiasis. Tendon rupture, which is in the label, based upon very sparse data, we did not see anything in that area. These were adjudicated. Now, we have heard a lot of noise, and I won't mention from whom, about whether lipid-lowering therapy is as effective in women as it is in men. Here are the hazard ratios. They're identical, 0.86 and 0.87, pretty much equal numbers of men and women. This drug worked just as well in women as in men. We actually had a lower hazard ratio in high-risk primary prevention than secondary prevention, although this, frankly, with subgroup analyses, we're very, very careful not to place too much stock in them. Limitations. Clearly, this is a select population with statin intolerance. We didn't study other populations. The addition of other therapies, including PCSK9 inhibitors, narrowed the LDL difference between bempedoic acid and placebo over time, which obviously did reduce the amount of reduction in morbidity and mortality. The pandemic created challenges, but we feel like we did a good job of overcoming them, and we did get vital status in a very high fraction of patients and full outcome data in more than 95%. So we conclude that bempedoic acid was well tolerated in a mixed population of primary and secondary prevention patients unable or unwilling to take a statin. This drug lowered LDL by 21.7% and CRP by 22.2%, with small increases in the incidence of gout and cholelithiasis. The primary endpoint, 4-component MACE, was reduced 13%, 3-component MACE 15%, myocardial infarction 23%, and coronary revascularization 19%. We feel that these findings establish bempedoic acid as an effective approach to reduce major cardiovascular events in statin intolerant patients. Now, let me just, go off script here a little bit and show you a comparison of the non-statin therapies and what they showed in their clinical trials. Ezetimibe tended to underperform. 3-component MACE was 0.9 and non-fatal MI 0.87. Evolocumab on 3-component MACE was 0.80 and non-fatal MI was very good at 0.73. Alirocumab was underperformed. 3-component MACE was 0.86 and non-fatal MI also underperformed, 0.86. Bempedoic acid was 0.85 for 3-component MACE, certainly in the same ballpark with these other therapies, and was 0.73 for non-fatal MI alone, which again was as good as anything in the non-statin world. So we think this is a really good result and makes the drug quite viable for these patients. The manuscript's in the New England Journal of Medicine. With this QR code, you can download it for free and read all the details that are there, plus a quite detailed supplement. So let me give you a final thought. You already know this because you do this for a living, but management of patients unable or unwilling to take statins represents a challenging and frustrating clinical issue. Regardless whether this problem represents the nocebo effect or actual intolerance, these high-risk patients need effective alternative therapies. The CLEAR Outcomes trial provides a sound rationale for use of bempedoic acid to reduce major adverse cardiovascular outcomes in patients intolerant to statins. Thank you very much for your attention, and I did leave plenty of time for some discussion.
Thank you, Steve. That was a great overview. And I'm sure everyone was impressed. But while we're looking at some of the questions popping in, I just want to ask you, with the benefit of bempedoic acid getting us our 20% reduction in LDL, would we expect better results in 3-point MACE, etc., if we use the combination of bempedoic acid and ezetimibe together, giving us a 35% reduction?
It's a great point. And FDA wanted to know whether bempedoic acid alone had a morbidity and mortality benefit. And we couldn't study the combination, but clearly this combination of bempedoic acid with ezetimibe, my colleague, Leslie Cho, who many of you know, was describing for me the other day a patient that came in that was just absolutely statin intolerant, that had an LDL of 180. And she put the patient on the combination of bempedoic acid and ezetimibe, and the repeat LDL in a month was 100. So the combination in some select patients can get really big reductions in LDL. And in most patients, as you point out, Guy, can get about 35, even 40%. So I think that's the way to use the drug, is use it in the combination pill. It's priced the same way, so you might as well get the free ezetimibe and get more LDL reduction.
Yeah, and further reduction in your CRP as well. So that's great point, Steve.
Yeah.
All right, here's a question from Dave Feldman. Is there an added component of LDL-C cholesterol and lipid lowering by increased LDL receptor activity in the hepatocytes? Comparable to statins, is there added component of LDL cholesterol reduction by increasing LDL receptor activity in the hepatocytes?
Well, it's a wonderful question, because this drug works exactly the way statins work. It deprives the hepatocyte of synthesized cholesterol, which results in an increase in the LDL receptor activity, which then removes LDL from the bloodstream. So that's exactly the same mechanism as statins. It upregulates LDL receptors just the same way statins do. It's just doing so upstream of HMG-CoA reductase.
And along that line, we have another question from someone asking your thoughts about adding bempedoic acid to statin therapy, since they use the same synthetic pathway. Does it make sense to use the two of them together?
There are studies. It turns out that because they work on the same pathway, in people on particularly high-intensity statins, the incremental LDL reduction from bempedoic acid is somewhat less. It's still about the same as ezetimibe. It's maybe 15 to 18%, but it's not 22%. So a little bit less efficacy on top of statins, but there still is LDL lowering efficacy when given on top of statins. And it's for people who we don't want to put on a PCSK9 inhibitor, adding bempedoic acid or the combination of bempedoic acid with ezetimibe on top of a statin. I'll tell you where I found it to be useful. We have people who are relatively statin intolerant. They can tolerate 10 milligrams of atorvastatin, but not more. And they still have LDLs that are not quite where you want them. You can add the combination of bempedoic acid with ezetimibe, and you can get them then to a reasonable target. Unlike our guidelines, I do treat the target.
Okay. Any effect of bempedoic acid on lipoprotein A?
We did this trial on a shoestring. This is a small company in Ann Arbor, Michigan. I really wish we could have measured a lot more biomarkers. We couldn't, so we just don't have the data. It's a great question. It's one that somebody could probably answer in a relatively modest sized trial, but we didn't do it in Clear Outcomes.
Okay. And do you routinely measure baseline uric acid and then uric acid while they're on the bempedoic acid?
I don't. What I do is if someone has a history of gout, then I'm cautious with bempedoic acid unless they are on a uric acid lowering therapy. If they're on allopurinol or febuxostat or some other, therapy and their uric acids are down, then they're probably at very little, if any, risk. So, but if you have a history of gout and you're not on a uric acid lowering therapy, probably ought to be used cautiously in those patients. Now, look, having a gout attack isn't the worst thing in the world. It's certainly a lot better than having a myocardial infarction. So, you have to use your clinical judgment about that.
And as you said earlier, do we need to be worried about the tendon rupture, or is that just put to rest after the Clear Outcomes?
I mean, I think it's put to rest. I mean,
okay.
The FDA put that in the label based on less than 10 cases. And I don't think it was a good call. But that FDA makes those decisions, and they did. And then we adjudicated it in the trial, and there was just no excess.
Okay. Here's an interesting question. Any data or within your data set that you have on the addition of bempedoic acid to PCSK9 therapy with regard to LDL, high-risk patients with elevated LDL? So any
we have
study?
Only a little bit of data. We have I think I showed in the lipid modifying, we have just a handful of patients on PCSK9 inhibitors that were in the trial. So it's really not enough information to answer the question. It is, however, a very good question. And it's one that, again, someone should try to answer.
I think that's a good point. Also, I was impressed to see in your last slide that bempedoic acid had a similar event reduction to evolocumab.
Yeah.
With regard to non-fatal MI and MI.
It did. Now, to be fair here, evolocumab was given on maximally intensive statins, not on placebo. And the LDL levels were, at the start, were lower. I mean, I think that the bigger treatment effect was certainly assisted by the fact that we had relatively high LDLs. Nonetheless, the point is that the result here puts the drug in the same ballpark as some other therapies that are, obviously more effective at lowering LDL. But the other non-statin therapies, none of them lower CRP. Ezetimibe monotherapy has no effect on CRP, and neither did the PCSK9 inhibitors. And so perhaps stay tuned, because we're going to analyze this. The anti-inflammatory effects are playing a role here.
I think that's a tremendous point. And as we remember from the early statin trials, it may not have been the potency of the statin, but the effect on inflammation that played a role. If you go back to even, the Physicians' Health study looking at CRP retrospectively.
Yeah.
Okay. All right. One question here: do you think the higher resting levels of LDL of this study contributed to the higher efficacy of the drug?
I think that's a fair statement. But of course, that's what statin intolerant patients look like. You know, they're the people who have high LDLs that we're not able to treat. The only requirement to get in the trial was to have an LDL of at least 100. We didn't want to do it in people that were on no statin and had an LDL of 80. You know, we wanted to treat people who had an LDL of over 100 and couldn't tolerate statins. So you could get in with an LDL that was, 100 or greater, but the median was 139, which is pretty high. But that's what patients who are statin intolerant look like.
Correct. And I think it's reassuring for us, especially for what we all do, that bempedoic acid reduces events and inflammation in this risk population.
It does indeed.
Okay. Does anybody else have any questions for the audience for Professor Nissen while we have him?
Well, if there are any others, first of all, let me thank you all for joining. I hope it was of some value to you. And, I see some names here of people I recognize. So let me say hello to you. And, I hope everybody found the talk informative.
Okay, so Steve, before I let you go, I knew there had to be one question for you. Okay. Is there any data on bempedoic effect on plaque morphology?
Yeah,
I told you.
Yeah, look, we did a lot of IVUS trials. I counted up 11 of them recently, and but I think that IVUS era is over, and there is no using CT angiography to measure plaque, in my view, is not an effective measure. So we really don't have contemporary data on the effect of any of these therapies on plaques because the CT technology just isn't there. Terrific.
All right. Well, I really appreciate you helping us out and, enlightening us. And we'll hope to see you at the next meeting.
I hope to see all of you soon. Bye-bye.
Thanks, Steve. Bye-bye.